Your next speaker will be Professor Dr. Hanan Hamid, and speak about anticoagulation revisited. تفضلي فضل.
Bismillah ar-Rahman ar-Rahim. First of all, it's my honor and pleasure always to be present in the annual meeting of the Lab Alex. الحقيقة يعني I start to feel home with you. فيعني أعذركم على إن أنا دايما موجودة وعلى ثقة presentation. Anyhow, what I'm going to do today is a clinical view of coagulation and the new anticoagulation thinking and progress. We know to have a proper hemostasis, we need to have good prevention of bleeding and at the same time prevention of thrombosis via many systems we have to abide to. We used to classify the coagulation cascade into intrinsic pathway and extrinsic pathway, and we kept for a decade or a couple of decades overwhelmed by the pathway of the tissue factor and the extrinsic pathway as a trigger for fibrin presentation and of course activation of the platelets. But actually in the last few years the concept is trying to change. I'm just reminding you of how coagulation factors are activating each other. But what is really surprising that once we have thrombin activation, we will have a feedback from activated thrombin to reactivate more factor VIII. And once we have thrombin activation as well, we will have reactivation or more activation of factor XI. So the mere presence of activated thrombin, even in small amounts, this will go into vicious circle of more activation of factor VIII, more activation of factor XI, which will start the whole cycle again, and we will go into snowball, which increase coagulation factor activation. So we have to keep that in mind because we will use that in applied targeting of a new anticoagulation. And to have a proper hemostasis, we have to have the balance between the bleeding risk and the thromboembolic risk, particularly when we tackle anticoagulation in a patient with a thrombotic event. We are all again keeping in mind that thrombosis happening in veins, but I assure you that more than 40% of cases, or 39 exactly percent, are having thrombosis either in the arteries or even intracardiac. I have many patients who have had intracardiac thrombi due to a congenital or acquired thrombophilic status. And again, whenever we go far, we go back to the base. The Virchow triad is still applicable of circulatory stasis, endothelial injury, or a hypercoagulable state. Whatever we go around, we go back to that basic fact. And before speaking about anticoagulation, we have to be aware that we are having special population, and them anticoagulation is a more difficult task. And those people are those who are overweight, extreme of age, chronic kidney disease, those who, especially with nephrotic, who are losing a lot of antithrombin 3 in their urine, those with liver disease, cancer-associated thrombosis, antiphospholipid syndrome, heparin-induced thrombocytopenia, the pregnancy-associated thrombotic risk, and the need of anticoagulation, and the problem of adherence, and those who are having feeding tubes, gastric feeding tubes. And we have to be as well aware of how to proceed in investigating and dictating the proper anticoagulation when we have unusual site of thrombosis. And the burden of thrombotic event with malignancy, the deaths in malignant patients, 10% of it is attributed to an associated thrombosis. So it is frequently happening, it causes 10% of mortalities, and it is difficult to treat. All of this we have to know before we attempt what are we going to give to our patient as an anticoagulation. Let us see the milestones of anticoagulation. We started early from the last decade, from the last century, In the middle of it, we start to have warfarin, which ironically was a rodicide drug. يعني ده كان drug لقتل الفئران مش للtreatment of thrombosis. Then we have in the 80s, starting of 80s or late 70s, the low molecular weight heparin from heparin. Then we have the era of DWACs in the 20s, the new millennium. And nowadays, maybe within few years, we will have in the market something else. These are the different anticoagulant mechanisms we know, targeting activated factor 10 or activated factor 2 by Pradaxa, which I think it is now falling down. We are less and less using Pradaxa, which is antithrombin, and I think if they are not going to produce second or third generation, the realized complication of Pradaxa will demolish its use from the market. Heparin and low molecular weight heparin targeting both thrombin and activated factor 10, while warfarin is a wide anti-factor inhibitors, including, which is one of the most important mechanisms of warfarin, including suppression of the natural anticoagulant produced by the liver. And that's why in some cases we could have a skin necrosis secondary to prolonged warfarin use due to suppression of these natural anticoagulants. These are the two old anticoagulants. I'm still a big fan of heparin. I do believe that heparin is not only an antithrombotic or anticoagulant agent. Heparin now is well known in manipulating the glucose tolerance and manipulating hepcidin-controlled iron metabolism in the body. So in the future, we might have other uses other than anticoagulation of heparin. Now, to remind you, heparin, low molecular weight heparin, and warfarin, where they do act on the coagulation cascade. This is the characteristic of unfractionated heparin and the low molecular heparin with the two types we know in Egypt. And here I'm emphasizing again of suppression of the natural anticoagulants, particularly protein C and S by the warfarin use. What are the indications of warfarin where nothing else could replace it? Number one, prosthetic valve, especially if it is metallic. Number two, antiphospholipid syndrome and severe renal impairment or hemodialysis, extreme of weight because the issue of absorption and fat conjugation, and others. But now the most important two indications, metallic valve prosthesis and antiphospholipid. And why warfarin is the drug of choice in antiphospholipid? Because this is not a personal impression or suggestion. We have 4 documented studies showing the superiority of warfarin on other anticoagulants, particularly the DWACs, and less frequent occurring with especially cerebrovascular accidents in patients with antiphospholipid. We can't deny that the new oral anticoagulants are opening new horizon for us in hematology for treating patients, and again, it is either targeting factor 11, factor 10 or factor 2. The most important piece of knowledge I would like to remind you and remind myself with is when you have creatinine clearance less than 65, the drug of choice to use with your patient is Eliquis, which is apixaban. It is the best drug to be used in renal impairment. The version have been of using, or the pattern of using anticoagulation in 2013, the lion's share was for warfarin. From 2015, most of the cases now are using direct oral anticoagulants. But in spite of that, wide variety, we are still having unmet needs in anticoagulation, like a major bleeding, which could be life-threatening in up to 10% of cases. We are using anticoagulation. The thrombosis is the leading cause of death worldwide, whether it is cardiac, cerebral, peripheral, pulmonary. So if you are jeopardizing 7 to 10% of patients who are receiving anticoagulation by life-threatening bleeding, this is a huge unmet need. Post-thrombotic syndrome is not well managed by the current anticoagulation, and of course, the pulmonary hypertension secondary to that, which occurs in up to 2%. So we are still having area in a special population in complication for new drugs as an anticoagulation. Then the scientists start to think out of the box and think of the coagulation factor in a different fashion. We do have two factors known as contact factor, 11 and 12. And in those patients, they start to find that those patients who are having deficiency in factor 11 or factor 12 are having decreased incidence of ischemic stroke and venous thromboembolism, no increase in intracranial hemorrhage, and spontaneous bleeding is uncommon. So I'm having coagulation factors. The deficiency of them protects the patient against thrombotic events. And this deficiency does not create neither spontaneous bleeding nor increased intracranial hemorrhage. So the science starts to think, why not to target the contact factors, particularly factor 11, as a target for anticoagulation, which will be more safe with less price we will pay. So this is the new concept in using the contact factors as target for anticoagulation. Do we have evidence-based that suppressing factor 11 will lead to better outcome as anticoagulation? This have been based on massive human genetic deficiency, genetic epidemiology, and animal studies. So this creates a new way to look into the coagulation cascade. And the scientists starts to realize that we do have a pathway which starts by the tissue factor. This will lead to what we call physiological hemostasis. And this will happen that the clot will occur at the wall of the blood vessels, sealing the creek and preventing bleeding. But the pathway which starts by the contact factors might end into pathological thrombosis, which will make the thrombus inside the blood vessel and the occurrence of thrombotic episode. So the scientists after that start to think, where are the different anticoagulation we are playing with, and how can we utilize that for better anticoagulation? They found that the warfarin, the DOACs, and even the heparin are working mostly on the overlap area here. Most of them, if not all of them, are working at that junction area between the prevention of bleeding and the increased thrombosis. So a new thinking of the rebirth of a new therapeutic target, which is contact factor, was based on the concept. We have a lot of papers like that, but we have the concept of let us separate or disengage the two pathways from each other. And this is through prevention of overlap of these two pathways by the different anticoagulants we know. And the point is to disengage this area inside the panel, and this what they call uncoupling of the pharmacologically uncoupling of the two pathway between the physiological hemostasis and the pathological thrombosis through targeting factor 11. So when we are inhibiting factor 11, we will have two benefits. Number one, decreased bleeding complications. Number two, reduction of thrombotic event, which is the best scenario we can have. And by examining these factor 11 inhibitors to many other anticoagulant factor, it was the safest ever zone concerning bleeding complication in anticoagulation. And this put factor 11 inhibition on top of the new research for a new way of anticoagulation. The story didn't stop here. It has been found that factor 11 particularly is highly secreted in thromboinflammatory conditions. So we are here about to target some trigger else than the mere fact of thrombosis. We are preventing or decreasing factor 11 activation induced cytokine inflammatory process. So we are targeting two birds by one stone. We are preventing thrombosis and we are decreasing inflammatory process. So the factor 11 have causes decrease in both thrombin production at the end of the day, decrease thrombotic event, and decrease cytokine response and prevent thromboinflammation. So the uncoupling again of the pathway is so beneficial in thromboinflammatory condition. So the relative advantage and disadvantage of factor 11 and 12, but mostly factor 11 new drugs, is that there are mostly directed preventing of thrombosis and preventing of excessive bleeding. Do we have recipes for that? هل احنا عارفين بالضبط احنا هنتارجت ايه عشان inhibit factor 11? This is through many mechanisms. To make long story short, these are the most important three strategies. Antisense oligonucleotides to prevent production of these factors from the liver, or antibodies to block or decrease these factors in the blood, or small molecules to obstruct the receptors and prevent and the product of these activated factor 11. Do we have drugs? All the list. We have antibodies, small molecules, natural inhibitors, antisense oligonucleotides, and aptamers. But look at that. For the first time in anticoagulation, we can give a drug once monthly or once weekly. So one shot every 1 month, or one oral or shot every 1 week as an anticoagulant. This is another new horizon for us. So the promise of contact pathway inhibition is attenuation of intravascular thrombosis without disruption of hemostatic function of the coagulation cascade, which is an ideal point of view. And the big question which have been aroused in the last ASH, are we going to see pharmacy near us selling us anti-factor 11? Yes, this is true. The last thing in the next couple of minutes is, what about local anticoagulations? Sometimes we don't need massive systemic anticoagulation. We might need a device, a patient on hemodialysis through membrane or something like that, and we need a new way of thinking of local anticoagulant. And from this point of view, the concept of anticoagulant macromolecules aroused, and on a reality, these anticoagulant macromolecules are used in the cardiovascular diseases for many devices, in the blood-containing maneuvers like hemodialysis or implant material, and we do have a lot of papers on that. Up to, we have periodicals which are interested in macromolecules, particularly anticoagulant macromolecules. طيب المacromolecules ممكن يكونوا أنواع؟ Yes. We could find them in nature. We have natural macromolecules, anticoagulant macromolecules, semi-synthetic or synthetic anticoagulant. Among the natural anticoagulant, plenty of things like planets, الجوافة، والأمارانث. الأمارانث دي مجموعة من العشبيات بتسمى القطيفة باللغة العربية، لكن بيدخل فيها حاجات كتير بنستخدمها للزينة، والثايم الزعتر مثلا، وحاجات كتير لما ناكلها ما بتخليناش عرضة أكتر للثرومبوز. ولهذا في بعض أماكن في العالم بالذات بيستخدموا الزعتر، فلسطين وفي أماكن أخرى عندهم نسب قليلة قوي من الثرومبوتيك إيفنتس بكميات كبيرة. موجود عندنا طبعا definitely في البلاك سنيك، لكن موجود في بعض الأسماك والسي فودز، particularly في أسماك موجودة عندنا في نهر النيل وفي بعض المايكرو اورجانيزمز. So we do have these natural anticoagulant macromolecules. بنستخدمها في ايه؟ الابلكيشن بتاعها زي ما حضراتكم شايفين في الكارديوفاسكولار ستنت، حاجه زي الالودد ستانس او الدراج الوتنج ستانس. كانوا يحطوا عليها زمان بلاتينم، دلوقتي بقى الكونسبت طب ما نحط الانتي كواجلانت ماكروموليكيولز to decrease the incidence of thrombosis in those patients. الدياليسيس ماشين، البايو الكترونكس، والحاجات الكتير قوي اللي بتستخدم في الفاسكولار سيرجري زي الارتفيشال فاسكولار امبلانتس. كنا بنبتدي بالتeflon زمان، دلوقتي الامور اتغيرت اكتر وابتدى يستخدم الناتشرال انتي كواجلانت مايكروموليكيولز. So to sum up with these all good news or surprises, anticoagulants are the mainstay of prevention and treatment of venous thromboembolism. Although direct oral anticoagulants have simplified prevention and treatment, bleeding still remain a concern, particularly in a special population. The current focus on activated factor 11 suppression could uncouple thrombosis from hemostasis and thereby preventing bleeding with anticoagulation. The phase 3 trial of factor 11 inhibitors for treatment and prevention is now in many drugs about to have to collect the results, and to assure you that in fast track, few of these drugs are now assigned for FDA approval, and we might entertain these drugs within a couple of years. With that, I finish my presentation. Thank you very much.
Thank you, Dr. Hanan, for your excellent presentation. The art of integration of clinical touch with physiological diagnostic approach. Thank you for your excellent presentation, and we open the floor